Welcome to SUBSIGMOID Dental College Lecturecast. Today's topic will be mandibular osteotomies. Mandibular osteotomies can be classified into ramus procedures such as the sagittal split osteotomy or the vertical subsigmoid osteotomy, subapical procedures like the anterior or the posterior subapical osteotomy, genioplasty, which can be either horizontal or vertical sliding or augmentation, and body osteotomy of the mandible. Coming to the mandibular anterior segmental osteotomy, it is indicated in advancement or to retrieve the lower anterior segment and to closed anterior open bite. The osteotomy is done after extraction of the first or second premolar depending on the movement required, and it is fixed either using transosseous wires or using a mini plate. The bilateral sagittal split osteotomy is the most versatile of the mandibular osteotomies. It is indicated in horizontal maxillary excess, horizontal mandibular deficiency, or in asymmetry. It is contraindicated when there are any deviations from the normal anatomy and in cases of recent trauma to the mandible. In 1957, Obvegesen and Trauner first described sagittal split osteotomy only by placing buccal and lingual horizontal cuts. In 1961, Dalpont changed the lower horizontal cut to a vertical cut on the buccal cortex between the first and second molars. In 1968, Untitled further modified the procedure by giving a shorter horizontal medial cut just posterior to the lingula instead of extending it till the posterior border. In 1977, Epker suggested several modifications which included minimal stripping of the masseter muscle and limited medial dissection. When the osteotomy is being made, care has to be taken so as to not injure the inferior alveolar nerve. Once the osteotomy is done, the mandible can be rotated, can be moved forward, or it can also be taken backward. Once the osteotomy is done, chisels and osteotomes are used to split the mandible and make it as a separate segment. The segment is then fixed using mini plates. The main advantage of the BSSO is that it's a very versatile procedure. Disadvantages are that it cannot be done in painful TMJ conditions. Stability, anterior open bite, and mandibular asymmetry are also possible. Complications can be intraoperative and postoperative. Intraoperative complications are nerve injury, hemorrhage, and unfavorable splits. Postoperative complications are relapse, malocclusion, and condylar position. The vertical subsigmoid osteotomy is yet another procedure which is used to set back the mandible. It is indicated in mandibular setback, correction of mandibular asymmetries, and in painful temporomandibular joint conditions. It is contraindicated in anterior open bite, advancement of the mandible, and recent condylar fractures. The main advantage is that it is useful in painful TMJ conditions and the incidence of inferior neurovascular bundle damage is lesser. The only disadvantage is that it cannot be used for advancement. Complications are bleeding, nerve injury, and bony interference. Once the osteotomy is done, the segment can be moved upward, downward, and it can be rotated and moved backward. Genioplasty is done to alter the size and morphology of the chin and changes in the surrounding soft tissues. Once the osteotomy is done, the chin can be brought forward or advanced, can be reduced, or can be augmented using a bone graft. Thank you.